Dear audience, dear chairs, my name is Patrik Kreuter and I would like to introduce my PhD topic, the latest advancements in digital orthodontics. I'm a first-year resident at the Department of Pediatric Dentistry and Orthodontics. My supervisors are Noemi Rózsa and Dorottya Bányai, my SMS is Petrona Martinakova, and my statisticians are Gergely and Aliz. My vision is to help more people smile confidently, and my mission is to contribute to the development of orthodontic guidelines, providing high-quality treatments without compromise. I have two ongoing projects, which are both systematic reviews and meta-analysis. The first one is titled Investigating the Differences in Root Resorption between Fixed Appliances and Aligners in Permanent Dentition. Fixed orthodontic appliances often cause aesthetic and hygienic difficulties during the treatment. However, aligner treatments are more comfortable and aesthetic, with less associated periodontal risk and patient satisfaction. Orthodontic treatment is one of the most common causes of root resorption, also known as a phenomenon of orthodontically induced inflammatory root resorption, and it can occur in up to 100% of the orthodontic treatments. Aligners previously showed a lower prevalence and severity of root resorption on radiographs. However, more accurate CBCT studies have been only conducted recently. Our aim is to investigate the effect of aligners versus fixed appliances in terms of root resorption based on this new evidence. We use the PICO framework, where the population is patients with permanent dentition. The intervention is aligners compared to fixed appliances, either conventional or self-ligating fixed appliances, and our primary outcome is root length decrease or root resorption on CBCT records, while the secondary outcome is the same measurement on radiographs. Our hypothesis is that aligner therapy causes less severe root resorption compared to fixed appliances. We've conducted our systematic search in 4 databases with the following search key, and after almost 7,000 hits, with an almost perfect agreement between the investigators, we have 6 eligible full texts, out of which 5 were included in the meta-analysis with 2 outcome measurements, root length change of the upper central and upper lateral incisors on CBCT recordings. Let me shortly introduce the results. In the first forest plot, we can see the comparison of aligners versus fixed appliances in terms of root resorption of upper central incisors. We can state, based on previous studies, that the root length change of 1 millimeter can be marked as a threshold for clinical significance. So root resorption below 1 millimeter is clinically insignificant. Our outcome measurement was a mean of root length change, so the decrease of hard tissue, thus the negative values can be seen on the plots. In our first analysis, 5 retrospective cohort studies with 287 patients were investigated. It's important to note that all of them are retrospective, so we will mark it as a weakness of these studies. We can state that none of the values exceeded 1 millimeter, so none of the groups presented clinically relevant root resorption, and there isn't a statistically significant difference between the groups either. However, it's important to notice that the I-squares of 99% and 48% mark a high heterogeneity, so the results should be acknowledged with caution. In our second analysis, we made a subgroup analysis of fixed appliances. We've compared conventional versus self-ligating appliances. And here we can see that none of the groups exceeded 1 millimeter, so none of the groups presented clinically relevant root resorption, and there isn't a statistically significant difference between them either. Our second main analysis was for the upper lateral incisors. In this case, we had only 4 retrospective cohort studies with 228 patients. And here, none of the groups presented clinically relevant root resorption. None of them exceeded 1 millimeter, and there wasn't a statistically significant difference between the groups. However, the I-squares of 96% and 82% also mark a high heterogeneity between the groups. Unfortunately, we didn't have enough data to make an analysis for lateral incisors comparing self-ligating and conventional fixed appliances, but we plotted the results here as well. The strength of our study is that it's the first quantitative analysis purely based on CBCT recordings. Only 2 arm studies were included, and the subgroup analysis of conventional and self-ligating appliances provided further valuable data. The limitations are that only retrospective studies were included. There was a high heterogeneity, and most of the available studies at least presented a moderate risk of bias. The conclusion is that within the healthy normal population, aligners and fixed appliances cause a similar amount of root resorption. The implication for practice is that both interventions can be used for the patients without the known risk factors. Self-ligating appliances are non-superior compared to conventional fixed appliances in terms of root resorption. And as none of the articles showed a clinically significant root resorption, CBCT measurements should not be used for the control of root resorption, as they cause a higher radiation for the patients and do not provide clinically relevant data. The implication for research is that there's a need for high-quality RCTs investigating the differences in root resorption, and future studies should investigate risk populations, as all of the included studies had rigorous inclusion and exclusion criteria to only provide data about healthy populations. Also, for easier analysis, more standardized populations, interventions, and outcome measurements are necessary in the future studies. Here you can see my progress. I finished the manuscript and it's currently under the revision of my supervisors. My target journal is the Journal of Dental Research. My second project is analyzing the failure rate and adverse effects with indirectly versus directly bonded orthodontic brackets, which is a systematic review and meta-analysis as well. The conventional direct bonding of multi-bond appliances requires high precision, as the misplacement of these orthodontic brackets could cause unwanted tooth movement. Indirect bonding, however, offers a more predictable and precise bracket positioning while decreasing chair time. Several articles show controversy regarding the differences between the two techniques in terms of the adverse effects of bond failure, plaque accumulation, or formation of white spot lesions. Since the latest reviews has emphasized the weakness of available evidence, new RCTs have been conducted, and our aim is to objectively compare these two interventions in terms of the aforementioned outcomes. Our clinical question is, was the performance of indirectly versus directly bonded brackets in terms of failure rate and adverse effects? Here we use the PICO framework as well, with the population of multi-bond appliances. The intervention is indirect bonding compared to direct bonding. Our primary outcome is debonding, also known as failure, and our secondary outcome is plaque accumulation and formation of white spot lesions. Our hypothesis is that indirect bonding is non-inferior compared to direct bonding in these terms. The clinical implication would be less chair time and similar occurrence of adverse effects. We've conducted our preliminary research and recognized some of the key articles. There's no ongoing reviews in this topic based on the Prosper registry, and now we are working on our own Prosper registration. So to summarize my projects, I have 2 ongoing systematic reviews and meta-analysis investigating the newest advancements in digital orthodontics, and I would like to thank you for your attention with a quote from Spinoza: "The highest activity a human being can attain is learning for understanding, because to understand is to be free." Thank you for your attention.
Regarding your first study, how did you come up with this 1 millimeter threshold? That would be my first question, and this is also related to the second question, that why didn't you group? So why the tooth type, like incisor or lateral central incisor? Why is it important? Why cannot group together? It doesn't matter which tooth included if you just your primary aim to find out the prevalence of root resorption.
Sure, thank you. So regarding the first question, actually there are several cutoff values in the literature, and 1 millimeter is the most rigorous one. The reason why we chose that is to show that even with the most rigorous cutoff value, we cannot see the clinical significance of these studies. And even though they've stated that aligners are superior and should be chosen over fixed appliances, it is not based on the evidence we found. So even with the 2 millimeter cutoff value, which is another common cutoff value in the literature, the results are even less significant, and we cannot state that the aligners are superior.
This cutoff value is based on the diagnosis, because there is a difficult to diagnose on the X-ray, and that's we need the cutoff value, because I think clinically the very slight resorption should be important, because this is a progressive disease. So if you find, and that's the third question come up, that what was the follow-up time after the, because if there is a 1 millimeter resorption, I'm pretty sure that a few years later there will be 5 millimeter resorptions. So that's why if it's a diagnosis-based cutoff value, because you cannot distinguish between 0.5 millimeter or 1.5 on the X-ray, then I understand. But it is a clinically based threshold value. I'm concerned about the follow-up time, because maybe later there will be a higher. Usually what we see in endo, that if there is a resorption, it's never end. So it's just proceed.
Yes, so let me address all of them and remind me if I forgot something. So with orthodontically induced root resorption, most of the available studies showed that after 6 months of treatment, and if you don't exceed the typical 2-year treatment, they do not really progrediate, which in other type of root resorption does occur. So the importance of treatment time is high, of course. This is one of the biggest confounding factors. There was one RCT included which investigated radiographs, and there they had a 6-month follow-up, and all of the others were finished cases with approximately 2 years each. So yes, the follow-up time is important, and if it's a prolonged treatment, then the occurrence of root resorption and the severity increases. Based on the clinical relevance, it was one of the most annoying things for me as well, that I couldn't find any articles, including the old ones by Sharpe at Allianz, who made this classification system of the Sharpe classification of root resorption, where they have 0 to 3 degrees of classification, and there they stated that the 3rd degree is severe, where at least 4 millimeters were present, or not present in this case, as it's a resorption. So the clinical relevance was, I think, quite hypocritic value in the previous studies, and they do not really represent the clinical significance, as even patients with 2 or 3 millimeters of root resorption can live freely without any symptoms. The retreatment, however, is sometimes tricky for these patients. And regarding the differences on the measurements of radiographs versus CBCTs, as it's only a summation of the pictures with radiographs, the angulation of the teeth or the torque values of the teeth can distort the results, so CBCT is more accurate. And actually one of the studies had volumetric measurements, and they found that even if there wasn't wasn't statistically significant root length change, there was a significant root volumetric change. So that's another aspect as well.